4 days, which is a total of a week, and then 1 milligram pill twice a day for 11 weeks. And the studies shown that people could stop smoking as early as 8 days if the medication worked, and there is good compliance with the patient. Actually, there is randomized controlled trials that show that the success rate is better with Chantis than with propylene. The success rate is up to 44%. So now let's move to diabetes. We all know that several epidemiological studies have shown that there is a strong association between diabetes and the development of peripheral artery disease. Peripheral artery disease is 5 times, because I have to change slides there and change slides here, sorry. So peripheral artery disease is 5 times more common in patients with diabetes. 30% of patients with diabetes have peripheral artery disease. So those primary care providers who have diabetic patients, they should probably look for any sign of symptoms of peripheral artery disease. And major limb amputation rate is 4 times higher in patients with diabetes than with patients with peripheral artery disease alone. So I'm not going to talk about therapeutic options about diabetes, insulin, so many metformin, etc. But what I want to highlight is that we have to achieve good glucose control in our patients. And according to the American Heart Association guidelines, the target should be less than 7% of the glycated hemoglobin. In older adults, though, we don't want to be so strict. Maybe we want a glycated hemoglobin less than 8, because older adults, because of the comorbidities and the age, could have the risk of hypoglycemic events. If you also have glycemic control in patients with diabetes, you can also prevent microvascular complications, progression of peripheral neuropathy, and other cardiovascular adverse outcomes. You say blood pressure over there? Blood pressure control? Yeah. Blood pressure control. Blood pressure is another important risk factor. It's believed that the risk to develop peripheral artery disease is double in patients with diabetes. But also it's important to know that blood pressure control is an important component of the risk reduction of cardiovascular events like a stroke, MI, and congestive heart failure in patients with established peripheral artery disease. So in my talk, I'm going to talk about studies later in my talk that are important to recognize risk factors in the and interventions in the reduction of cardiovascular events in patients with peripheral artery disease. It's very important also to check the blood pressure in both upper extremities in the patients to exclude occult Statin stenosis. When I was in my practice, since I started with Dr. Haqqani, we find out that many patients have a big difference in the blood pressure in different arms, more than 30. And some are asymptomatic, but some start after further questioning, they start saying, yeah, when I use my left arm, because this usually happens in the left side, they have like a numbness in the arm when they're using the arm, or they have a weakness, or they start having dizziness or syncope. In that case, we could diagnose supplying steel syndrome, and they deserve further evaluation, like a CT angiogram of the chest, and ultimately angiogram. According to the the American Heart Association guidelines for patients with peripheral artery disease, the target blood pressure below 140 over 90 is recommended. And there are no comparative trials to support the use of one particular class. However, it seems like the ACE inhibitors could be the preferred drug. And I'm going to show you this study. It's the HOPE trial, which means Heart Outcomes Prevention Evaluation Study, that investigators did a randomized trial in more than 9,000 patients. And a group of patients received Ramitri and the other group received placebo. So in a subgroup of 4,000 patients with peripheral artery disease, those who received Ramitri had a 25% reduction in number of major cardiovascular events, like MI, stroke, cardiovascular event related death. Based on another subgroup analysis of more than almost 5,000 patients which have normal blood pressure, the benefit of Ramitri was also present. So investigators kind of extrapolate this to saying, maybe in patients with peripheral artery disease with normal blood pressure, the use of ramipril could be beneficial. What about beta blockers? We also use beta blockers in our peripheral artery disease patients, especially in those with a history of cardiac disease, especially the patients with hyperventilation, supraventricular tachycardia, and those patients who are going to have surgery. It's very important to evaluate and use beta blockers in the perioperative management of patients with peripheral artery disease. Okay, so now moving to antiplatelet therapy. We all know that antiplatelet therapy is indicated to reduce the risk of cardiovascular events in patients with peripheral artery disease. It's a class 1A recommendation. What that means that physicians should offer antiplatelet therapy to this patient. So antiplatelet therapy is indicated to reduce the risk of MI, stroke, and vascular death in individuals with symptomatic lower extremity peripheral artery disease. So what is involves symptomatic lower extremity peripheral artery disease involves patients with intermittent claudication, with critical limb ischemia, patients who have prior lower extremity revascularization surgery, and prior amputation for ischemia. The options are aspirin. Apparently, studies show that low dose of aspirin or high dose aspirin is not going to make a big difference. And the second option is clopidogrel, 75 milligrams PO daily. I think in coronary artery disease patients, studies have shown that the use of Flavis could be more beneficial than aspirin, but I think in peripheral artery disease it's about the same. The other recommendation is that antiplatelet therapy can be useful to reduce MI, stroke, or vascular death in asymptomatic individuals with an ABI less or equal to 0.9. So by testing, they have peripheral artery disease, but they don't have symptoms. But the class 2A recommendation means it's reasonable, makes sense. Now, patients with asymptomatic peripheral artery disease who have borderline ABI, maybe around 0.9 to 0.9 is questionable. More studies need to be done. Now, what about dual antiplatelet therapy? The combination of aspirin and Flavis may be considered to reduce the risk of cardiovascular events in patients with symptomatic lower extremity peripheral artery disease, but also if they have multiple risk factors and they don't have the increased risk of bleeding. That's a class 2B recommendation. That means that maybe consider more data, additional data is needed. And they come out with this recommendation based on this study called Charisma trial. That means that clopidogrel to high atherothrombotic risk and ischemic stabilization management and avoidance. So what they found is that basically the use of dual antiplatelet therapy decreased the rate of hospitalization for unstable angina, transient ischemic attack of PIA, and revascularization in these patients. In the primary efficacy endpoint, that means acute MI, stroke, or cardiovascular death, apparently there was no significant difference. But also they found that moderate bleeding was more prevalent in patients with dual antiplatelet therapy. When I was doing this presentation, to be honest, I find out when I was reading an article in the New England Journal of Medicine from March 2016, they mentioned about this new antiplatelet or antithrombotic agent called Sontivity. Anyone has used this drug before? Right hands? Nobody? The generic name is Vorapaxar, and the dose is 2.08 milligrams PO daily. This is an antiplatelet agent that blocks the thrombin protease activated receptor 1 and should be used with either aspirin and Flavis. Apparently there is no data showing that it's effective using as a monotherapy or with other antithrombotics, and has been approved by the FDA in 2014. It's apparently they did studies and they shown that the medication reduced the rate of combined endpoint of cardiovascular death, MI, CVA, or urgent coronary revascularization. And in a subgroup of patients with peripheral artery disease, that is our kind of patients, the drug reduced the risk of acute limb ischemia and peripheral revascularization events. So it's something to keep in mind. What about anticoagulation therapy? They did the studies with warfarin. They didn't do much studies with other novel anticoagulation agents like Xarelto, Eliquis. And the study says that in the absence of any other proven indication of warfarin, in addition to antiplatelet therapy, to reduce the risk of adverse cardiovascular events in peripheral artery disease patients is of no benefit and potentially harmful due to increased risk of major bleeding. So apparently, class 3 recommendation means you shouldn't use it because it produces more harm. And this is based on the WAVE trial, where more than 2,000 patients with carotid artery disease, playing artery stenosis, and peripheral artery disease, they were divided in two different groups. Those who receive warfarin and antiplatelet agent, and others who received antiplatelet agent alone. Over a 35-month follow-up, there was no benefit in the combination therapy in preventing adverse cardiovascular events. And significantly, there was increased risk of hemorrhagic stroke. Actually, increased risk on fatal severe bleeding. Severe bleeding indicates intracranial hemorrhage or bleed that requires surgical intervention or transfusion of more than 4 units of red blood cells, or the patient died. Now, the use of the statins. This is straightforward because the treatment with statins is recommended. They did multiple studies in patients with peripheral artery disease, and they found that improved symptoms of claudication in this patient, and also improved the pain-free walking after at least 6 months of treatment with a level of evidence B. That means at least one randomized trial or multiple observational studies. And so what are the mechanisms? The mechanisms apparently include reduction in the plate size, improvement in the vasomotor regulation of the blood flow, promotion of angiogenesis, and increased skeletal muscle metabolic function.